The purpose of this program is to teach you how to recognize and respond to these reactions, and to do so in the first few minutes, which may be critical to saving your patient's life. In every contrast-enhanced imaging procedure, preparation is the key to successful recognition and response. And a key part of preparation is knowing your patient.
Good morning, Mr. Jacobs. I'm Pam Stevens. How are you today?
All right, I guess.
Good. I see you're here to have your kidneys x-rayed, and I'd like to go over the procedure with you. I'd also like to ask you a few questions.
Okay.
The pre-procedural interview is important because it not only makes the patient more comfortable by establishing rapport, but it allows the radiologist to get to know the patient and his or her medical history. If you know the patient, their risk factors, how they communicate, you may well be able to pick up on subtle signs of an adverse reaction and thereby react more quickly.
Do you have any allergies?
No, not really. As a kid I did, but not anymore.
What allergies did you have as a kid?
Oh, I got kind of stuffed up during the summer. Hay fever, I guess. But I don't have it anymore.
All right. What about allergies to other things? Have you ever had a reaction to seafood or any medications?
No.
Are you taking any medications right now?
No, just aspirin now and then.
Although risk factors such as allergies, asthma, heart disease don't guarantee that a reaction will take place, they can and should alert medical professionals to early symptoms of adverse side effects. When asking about medications, it should be noted whether the patient is on any cardiac or hypotensive medications such as alpha or beta adrenergic blocking agents. These medications can impair the efficacy of epinephrine treatment or actually initiate a depressive response and result in a fall in blood pressure.
Now, Mr. Jacobs, have you ever had one of these exams before where they gave you an injection and then took some x-rays?
Yeah, I had one a few months ago.
Oh, how did that go?
Okay, I guess.
Do you remember if you had any problems or if you experienced any discomfort during the exam?
Well, nothing really happened, but I remember feeling warm at first, and that made me nervous. But as I said, nothing happened.
Did you tell the doctors how you were feeling?
No. See, they told me that I would probably feel something when I got the injection. And I didn't want to complain, you know. I mean, they know what they're doing, so I just decided to wait it out.
Asking about previous experiences with contrast media is very important. It reveals how the patient handled the procedure, both physically and psychologically. For example, despite Mr. Jacobs' remote allergic history, his previous contrast procedure appears to have gone without incident. But just as important and significant is Mr. Jacobs' communication of his experience. He doesn't like to complain, even when he's anxious or feeling discomfort. The technologist should note that, number one, Mr. Jacobs is still anxious about the procedure, which might even be a risk factor. And two, that he tends to downplay that anxiety and may not mention discomfort at all.
Anxiety, allergies, heart or kidney problems, and the use of certain medications are all risk factors for contrast media reactions. The patient interview not only gives medical professionals a chance to reassure the anxious patient about the procedure, it also allows them to pick up on the patient's subtle verbal or physical cues that may be prodromal to a serious reaction. The fact is that patients rarely progress to serious life-threatening reactions without some warning. Therefore, everything the patient expresses during the procedure, whether it be verbal or nonverbal, must be observed and considered as a potential serious reaction. Just as important as patient preparation is a fully equipped and staffed imaging facility. Each radiographic suite should be equipped with oxygen, suction, ambu bag, oral airway devices, intubation capabilities, and vital monitoring devices. Also, to avoid AIDS or TB exposure, a mouth-to-mouth resuscitation device should be available in each room. Basic treatments including IV fluids, atropine, epinephrine, and beta-agonist inhalers should be readily accessible. Some facilities also keep specific contrast reaction kits or carts consisting of epinephrine, atropine, Benadryl, corticosteroids, and other therapies stocked and ready inside the suite. The effective use of these treatments depends on the immediate availability of trained emergency personnel. Therefore, each room should have a telephone or intercom system by which emergency personnel can be alerted quickly and easily. Telephone, intercom, or pager numbers of trained personnel for intubation and CPR should be clearly posted. Contact should include an anesthesiologist, an anesthetist, and a code team. Also, because most reactions occur within the first few minutes of injection, the radiologist should be immediately available during this time and for the duration of the study. Finally, all radiology personnel should know the location of the nearest crash cart, a fully stocked and equipped emergency supply cart that can be wheeled into a radiographic suite for more intensive treatment. Daily or weekly checks should be performed to make sure the cart is adequately stocked and in operating order. The preparation of the patient in the facility, while extremely important, depends on your readiness to address any emergency that arises. Remember, our responsibility is to recognize and respond, and to do that within the first few minutes of the reaction. Recognition begins by becoming knowledgeable about the prodromal signs and symptoms of reactions and their degrees of severity. Prodromes, or predictors of potential severe reactions, include cough, headache, dizziness, anxiety, itching, pallor, chills, shaking, sweats, and early signs of respiratory difficulty. Such side effects can be classified as mild, moderate, or severe. Most reactions signaled by these prodromes remain mild in nature and require no treatment other than reassurance and observation. Moderate reactions include more severe expressions of these side effects, plus possible systemic symptoms, including pulse and blood pressure fluctuations, dyspnea, laryngospasm, and bronchospasm. Moderate reactions may progress rapidly to much more severe life-threatening reactions. Additionally, convulsions, patient unresponsiveness, and paralysis may signal severe reactions involving the central nervous system. All severe reactions require immediate treatment, support, and usually hospitalization.
Any of the reactions that we've been talking about can occur by themselves or in combination with one another. The important thing to remember is that even mild to moderate reactions may progress, even fairly rapidly, to a very severe life-threatening reaction.
Once the symptoms of a reaction or potential reaction have been recognized, radiologists and technologists should respond accordingly with the basic ABCDs of intervention. A, assessment and airway patency. Response begins by immediately assessing the patient's condition and calling for help. If assessment indicates resuscitation, respond by 1, clearing and positioning the patient's airway for optimal resuscitation. 2, administering oxygen. 3, elevating the patient's legs. And 4, initiating 1 to 2 liters of rapid fluid replacement. Also at this time, the patient's vascular access should be secured or improved with a large bore needle or second IV line.
Reactions often manifest themselves as difficulty in breathing, labored breathing, or hypotension. Therefore, assessment and establishment of an adequate airway, as well as providing the patient with oxygen therapy, is critical to the resuscitative effort. Fluids administered rapidly and through an intravenous route may be all that is required to support the resuscitative effort, thereby obviating the need for any drug therapy.
B, begin breathing. Depending on the status of the airway, various respiratory assistance devices can be used to assist the patient's breathing. They are an oxygen mask or nasal prongs hooked up to oxygen, a combination resuscitation mask and airway device with a protective mouth barrier, and an ambu bag. C, circulatory assistance. Circulatory assistance is accomplished by initial crystalloid or colloid fluid replenishment. This may be enhanced by using pressure bags and elevating the legs. Constant evaluation of the patient's condition is important to the effective management of the severe contrast reaction. Blood pressure should always be taken. Cardiac monitoring, including EKG assessment, should be promptly instituted when available and used in the consideration of subsequent therapies.
Failure of circulatory assistance, or for that matter, any of the ABCs already described, would be a reason to call for a code team response. Of course, it is assumed that the basic ABC principles have been already adhered to if there is a failure of the circulatory assistance attempts. Furthermore, uncertainty on the part of any of the personnel in attendance to a patient who's undergoing a contrast material reaction would itself also be a valid indication for calling for a full code team response.
D, drug therapy. Drug therapy will depend upon the radiologist's categorization of the type and degree of reaction. Initial drug therapy may consist of intravenous epinephrine or atropine and fluids. This first aid approach must be initiated quickly, and patient status must be constantly reassessed. EKGs, pulse oximeters, and patient monitoring devices must be available to determine the effect of intervention and the progression of the reaction. These fundamentals, or ABCDs, are standard operating procedures for the treatment of most contrast media reactions. Next, we'll review the implementation of these procedures as they pertain to individual patient cases. We'll assume that the decision to use the contrast media, the type of contrast media selected, and any pre-medication strategies instituted in these patients has been thoroughly investigated and weighed against the alternatives. We'll also assume that consent and compliance with local standards or regulations have been obtained. Art Jacobs is 56 years old. The pre-procedural interview has identified 2 potential risk factors: general anxiety and hay fever during childhood. While his history indicates no previous kidney or heart problems, he's rather overweight, which should alert the professional to potential difficulties if intubation or CPR is required. With these considerations in mind, the urogram begins.
Mr. Jacobs, how you doing?
All right so far.
Now, when we give you the injection, you may feel a little warm, but that's normal, so try not to worry.
All right, the needle's in. Now, we're going to begin the injection now. You let me know if you feel anything funny.
Okay.
Also, when we begin taking the x-rays, you're going to have to lie very still. Now, I'll let you know when we begin, all right?
Uh-huh.
Okay. We're about to take the films now, Mr. Jacobs. How are you feeling?
All right. All right, I guess.
How are you doing, Mr. Jacobs? How do you feel?
Not too bad. Are we done now?
No, we have a few more films to take. I noticed you swallowing a little hard. How does your stomach feel?
It's felt better. Kind of queasy. And I've got this, I don't know, this metallic taste in my mouth.
Mm-hmm. A lot of people feel that way when they get injected with the contrast material. It usually goes away quickly. You let us know if it doesn't, all right?
Uh-huh.
Although Mr. Jacobs was reluctant to say anything, the technologist picked up on his exaggerated swallowing and determined that he was experiencing nausea in response to the media injection. Closer observation indicated no changes in the patient's pulse rate or breathing, or any skin manifestations of a reaction.
These types of reactions can be classified as mild or physiologic or even minimal vasomotor responses. The important thing to do at this point is to reassure the patient that indeed these are mild and temporary phenomena.
Mr. Jacobs, I noticed you scratching your side. Does your skin feel a little itchy or tingly?
Well, a little, not bad.
We're almost done with your exam. Let's take a look here. Dr. Garrick, we've got some hives. Mr. Jacobs, I know you're feeling a little itchy, but how do you feel otherwise?
My stomach doesn't feel great.
The technologist assesses that despite the onset of hives, no respiratory or hypertensive symptoms have developed. Heart rate is slightly increased, which is probably due to anxiety. Because of Mr. Jacobs' allergic history, the technologist alerts the radiologist. At this point, further therapeutic options might be considered. In this case, the radiologist opted for no treatment. Personnel kept close observation as the injection of contrast had just been completed. Symptoms subsided within minutes, and as Mr. Jacobs relaxed, the procedure was completed without incident. But if this vasomotor response had been accompanied by the rapid onset of sneezing, wheezing, stuffy nose, throat itch, facial swelling, shaking, or chills, then Mr. Jacobs would have required alternative treatment.
Mr. Jacobs? You're all right. Mr. Jacobs? Dr. Garrett? Mr. Jacobs, you're all right. Just relax. We're going to make you breathe a little easier.
Marie, what's his blood pressure?
It's normal by palpation.
Pam, have you checked his IV line?
IV secure. Bad reaction.
Administering epinephrine. All right, Mr. Jacobs, that's it. Now listen to me. Listen to me. Just relax, okay? Just relax now.
In an emergency situation such as this, epinephrine should be administered in doses lower than indicated in the package insert. That is 0.1 to 0.2 milliliters of a 1 to 1,000 concentration, subcutaneously, as in this case, or if given IV, a 1 to 10,000 dilution administered slowly at a rate of 0.1 ml per minute with careful patient monitoring. Physicians must consider several factors when choosing mode of administration. First, obviously, the availability of an intravenous line. Secondly, the presence or absence of circulatory collapse or poor peripheral perfusion, either of which would mitigate against subcutaneous administration. In true emergency situations, if no other routes are available, epinephrine can actually be given via the tracheobronchial tree. In addition to epinephrine, the use of a beta-agonist inhaler can also be considered. The efficacy of Benadryl, with or without cimetidine or ranitidine, is not clearly established, but may, at least on a theoretical basis, be appropriate for some patients.
Because the radiology personnel were adequately prepared, the ABCDs were initiated almost simultaneously, resulting in effective intervention. Because of Mr. Jacobs' allergic history and initial presentation of hives, the technologist was prepared with a plan of action. However, if initial treatment had not significantly alleviated severe laryngeal edema and bronchospasm, intubation and further drug therapy would have been indicated. Throughout treatment, monitoring should be constant and therapy should be tailored to patient response and progress. 42-year-old Robert Waters has been recommended for a urogram. His chart and interview confirm that he has no known allergies or sensitivities to medication and no history of kidney problems. However, his last physical indicated mild hypertension, and he's been taking a beta blocker for approximately 3 months. The radiologic technologist assesses that the patient is sufficiently communicative and well prepared.
Mr. Waters? Mr. Waters, you doing all right here?
On Thursday, yes.
Can you understand me, Mr. Waters?
That taste in my mouth.
Mike, get me some help right away.
The radiologist recognized Mr. Waters' nonverbal cues immediately. Contrary to his easygoing, communicative manner in the interview, he has become uncomfortable, less responsive, and his speech is significantly slurred. Further assessment shows the patient exhibiting profound shock, non-vagal, with severe hypotension and tachycardia. Patient is somewhat responsive, but vitals indicate pending progression to shock and potential pulmonary arrest with circulatory collapse.
Okay. What kind? You got any reading yet?
His blood pressure is very low.
Yeah. How much?
Systolic, 80 maybe.
Okay, then we're going to need an angiocath in the other arm, and he's going to need lots of fluids.
If the patient is still somewhat responsive, as Mr. Waters is, immediate intervention should be implemented in compliance with the ABCD first aid approach. The two-person team should work together to ensure airway patency and circulatory assistance. But before any drug therapy is initiated, consideration must be given to the potential interaction of these drugs with the beta-adrenergic medication noted in Mr. Waters' history.
Blood pressure slightly higher, pulse stronger, blood pressure now about 100.
He may be stabilizing. Mr. Waters, can you hear me?
All right. I'm all right.
Jackie, I need you to call his referring doctor. And also, let me have a look at his chart.
Okay. I'll be right back.
He'll probably need to be admitted.
In Mr. Waters' case, aggressive fluid replenishment corrected hypotension and reestablished and maintained cardiorespiratory function. No code was required, but careful monitoring, usually in the hospital, will be needed for a significant period after this type of reaction. If Mr. Waters had been immediately unresponsive, a code would have been called and more extreme life support measures would have been assumed by emergency personnel. Gail Thompson is 38 years old. She's being examined for possible neurological difficulties. The radiologic technologist notes that Gail has a quiet but nervous type personality and that her skin color is normally pale.
Mrs. Thompson, we're going to begin the injection now. Go ahead. Mrs. Thompson, how does that feel?
A little cold, that's all.
That's normal. Now we're going to take some scans. I need you to lay still and to breathe quietly. Let me know if you feel anything funny, especially where we put the needle in, okay? Renee, she seems a little nervous. She keeps fidgeting with her hands. Mrs. Thompson, how are you feeling? You seem a little restless.
I just feel a little, I don't know, I feel like I have to go to the bathroom.
Are you still feeling cold?
Yes, kind of. But you know, I'm always cold. Now I feel like I'm gonna faint.
Renee, I better get her out of there. Mrs. Thompson, it's good that you told us. Just relax, I'm gonna be right there. Let's see what I can do for you here. See how your pulse is. It's a little low, it's below 40. Renee, stop the injection. And you better bring me some atropine, please.
Dr. Clark suspects Mrs. Thompson is having a reaction. Her initial observation notes bradycardia, uncharacteristic pallor, and sweating. It was difficult to determine at first whether the patient's initial fidgeting, faintness, and urge to urinate was a nervous response or a signal of a serious reaction.
Mrs. Thompson's symptoms are typical of what would be called the so-called vagal or vasovagal reaction. While most of these are mild to moderate in severity, they do respond to moderate doses of atropine, in this case 0.6 to 1 milligram of atropine given intravenously. Should be given slowly and actually can be repeated every 3 to 5 minutes up to a total dose of 2 milligrams. Now, while respiratory symptoms usually aren't a part of the typical or so-called classic vagal reaction, it's still very important to monitor the airway, make sure that it's patent, as well as monitoring the vital signs to make sure that the patient has totally returned to normal, to make sure also that there's no need for any further assistance or intervention.
Systemic BP is coming up. It's slightly over 80. Heart rate is still down, though, at about 50.
Continue pushing fluids wide open. Mrs. Thompson, how are you feeling now?
Better.
Still kind of faint? Well, we'll try and fix that for you. Just relax.
Gail Thompson's symptoms disappeared gradually, and the procedure was completed without further incident. Each of these reactions demonstrates standard medical responses that have proven effective in clinical practice. In review, they are reassurance and observation for vasomotor reactions, fluids and adrenergic drugs for anaphylactoid reactions, intravenous fluids supplemented by pressor drugs for hypotensive response, and IV fluids plus atropine for vagal reactions. We've shown you why it is critical to be prepared for adverse reactions to contrast media, despite their low incidence and despite the fact that most reactions are mild to moderate. We hope that this program will help prepare you to carry out life-saving measures. We also hope you'll never have to use them. But as healthcare professionals, you must assume the responsibility that patients' lives may someday depend on your readiness to recognize and respond.